let's talk now a little bit about pediatric genitourinary disorders. I want to go over some of the more common things that you're going to see in primary care, and then maybe some of the more red flag diagnoses that are not necessarily super common, but they are things that you do not want to miss and things that you want to make sure you have very early and prompt management of in order to best and optimally treat your patient. All right, so in terms of genitourinary disorders for pediatric patients, one of the most important things that you want to make sure you have a good idea about is urinary tract infections. Okay, so the way that you manage urinary tract infections depends on a lot of things, but it really can be broken down into three main factors. Okay, whether or not it is uncomplicated and just dwells in the bladder. Okay, so that would make it an uncomplicated cystitis. Whether or not it is uncomplicated pyelonephritis. Okay, so that means that it has actually gone beyond the bladder and has now migrated from the lower urinary tract to the upper urinary tract and has reached the kidneys. And then lastly, complicated pyelonephritis, in which case the child is at risk for renal damage. And you would want to make sure that you're acting promptly. Now, we also like to classify these treatments in a child that's less than 5 years old. And the reason why is those more complicated urinary tract infections or pyelonephritis, etc., are usually in your younger children. I have cared for adolescents and older children who have had a pretty severe pyelonephritis, but it is not nearly as common as those urinary tract infections or complicated pyelonephritis infections that are in children younger than 5. So this algorithm found in your Burns book is actually a really excellent tool to use in primary care to help you know exactly how to manage these patients. Okay? So now, when you're talking about symptoms, it depends also on the age. Okay, so the things that a child who is in infancy stage is going to come in with are totally different than the things that a child who is in an older child. Okay, so for neonates, some of the clinical findings for urinary tract infection in babies who are very young, okay, neonates would be less than 28 days or 28 days and under. You may see jaundice, okay, you may see hypothermia. Okay, it's very common for a neonate to actually, when they are septic or when they're having problems with infection, to have a lower temperature as opposed to a higher temperature. You may see things like failure to thrive. Okay, they're not eating, they're vomiting, they're having diarrhea, possibly cyanosis, abdominal distension, or even lethargic. Now, the chances of you seeing a neonate with a severe urinary tract infection are not going to be super common, okay? And usually when we do see that, it is typically a result of a child who has a VUR or vesicoureteral reflux, and we'll talk about that a little bit later in this presentation. But it's important to know the symptomology of your younger neonates as compared to your older infants and your older children because they're just completely different. Obviously, they can't talk to you. So infants older than neonate, okay, so that's going to equal your 1 month to about, 11 months old. You're going to see irritability in these children, okay, possibly fever. Usually they do have fever over about 101. They may have poor weight gain, okay, difficulty feeding or difficulty eating. Vomiting is a big one. Okay, so a child who comes in to see you with fever, vomiting, and no other really good signs on physical exam that there's something going on, that kid needs a urine checked, all right? And the main reason is because if you don't have runny nose and congestion and cough or something going on with the kid's ears or something going on with the kid's eyes, and there's no obvious source of infection, well, what are the three main things you worry about with sepsis as far as infection goes in a kid? You worry about blood, you worry about urine, and you worry about cerebrospinal fluid. So urine is going to be that thing that you check if you have an infant that comes in with those symptoms and no obvious sign on exam. Another thing you may notice in an infant who has a UTI is a malodor in the urine. Parents will tell you the urine just stinks. It's really strong. It's stronger than I've noted before. It's not got it's got a different smell than what I've seen before in them. They may have abdominal pain or colicky type movements, pull their legs up and to their tummy, or they may even actually be dribbling urine when the parents change their diaper. They may notice dribbling urine in females or males. Now, urinary tract infections are far more common in female infants than males. Okay, so if you have a male who comes in to see you with a fever and you're suspecting a urinary tract infection, there is probably more than just a UTI going on with that male boy. And the reason is males have longer urethras. Their chances of getting infection in that longer urethra is less. So usually it's going to be your young girls who get urinary tract infections because their urethra is shorter. All right, next, toddlers and preschoolers. They're going to come in and they're going to have funky, altered voiding patterns. Okay, if a toddler age or a preschool child has got a urinary tract infection, they may be urinating on themselves. They may be having increased frequency, increased urgency. Urine might, just the same as infants, have a really strong smell, maybe some abdominal or flank pain as well. Urinating in the bed, having accidents during the day, which is not common for them normally. Vomiting, okay, fever, of course, and they may also have some diaper rash or erythema going on in the area of their diaper. Lastly, school-age children and adolescents. Now, that's not on this algorithm, but we will go over because it is a little different. You're going to see the classic dysuria, frequency, urgency, and discomfort. Malodor and uresis is very similar to the toddlers and preschoolers. Abdominal flank pain, vomiting, diarrhea, malaise, and then also, of course, fever and chills. Now, to get back to this algorithm here, one of the most important things you want to pay attention to is this third line here, okay? How do you treat these kids? If they've got an uncomplicated cystitis, all right, so basically they're coming in with their urinary tract infection symptoms, but they don't have fever, they have a positive urine, you're going to give them PO antibiotics, okay? And first line antibiotics for urinary tract infections, it really does depend on the child, for sure, okay? But first line is going to be Bactrim, and then also your cephalosporins. For uncomplicated cystitis, you can actually also give amoxicillin or amoxicillin clavulanate. There's other cephalosporins would be like cephalexin, cefixime, cefpodoxime, and ciprofloxacin is really going to need to be reserved for your children who are older than 18 unless you've got a really good indication to give that, okay? We don't like to give fluoroquinolone PO antibiotics to kids too often if we can stay away from it. All right. So next, for your uncomplicated PILO kiddos, and these are for children greater than or equal to 3 to 6 months, they have to be well hydrated. Okay, they have to be not vomiting, and they have to be having abdominal pain for the uncomplicated pyelonephritis being going on, or no abdominal pain, sorry. So they may need IM antibiotics. Okay, so they may come in to see you at 6 months old. They're doing really well, drinking good, but mom says to you, I just know there's no way she's going to take these antibiotics. You may give her or him a shot of IM Rocephin instead. And that can treat the urinary tract infection. If the child has complicated pyelonephritis, so that means they're feverish and they've got vomiting, they may have diarrhea, that is not something that you're going to be able to manage in the office, and that is something that you will need to refer out. Okay, so again, refer out, by refer out, I mean that they need inpatient treatment and management with hospitalization. All right, so next I wanted to go over, let's see if I can find the picture for that. I had a really good one. There it is. All right, so children, we were just talking a little bit about vesicoureteral reflux. Okay, so vesicoureteral reflux is graded between 1 and 5. Now, if it has not reached the renal pelvis yet, then it's a grade 1 and the risk is a lot lower. So this chart actually starts with grade 2, which has already reached the renal pelvis. And the risk, obviously, with each increase in grade is going to go up. Okay, so grade 2 extends up to the renal pelvis, but there's not going to be any dilation here. See how there's no dilation here in the ureter and there's no dilation here in the renal pelvis area. Grade 3 extends. There is dilation of the ureter and the renal pelvis, and then also in these areas up here. And then just keep on going to grade 4 and grade 5. Obviously, the higher the grade, the more renal pelvis and renal scarring and damage that you are going to see in that child. So, what does vesicoureteral reflux mean? It is very simply regurgitation of urine from the bladder into the ureters and then possibly into the kidneys. Well, the problem with that is that if there is infected urine, okay, that has the potential to become pyelonephritis, that is when there's a major issue. So if infected urine from the bladder reaches the ureter and in the kidney, then we're causing pyelonephritis, and that can be very damaging to the kidney when it's done over and over again. And so you can see that a kid who has, even here, and here risk, and look how dilated these ureters are and how easy it would be for urine to back up here into those kidneys. That is when you see your kid who comes in with recurrent UTIs, and this is actually found on a VCUG, so vesico voiding cystourethrogram, sorry about that, for any child who has vesicoureteral reflux. And if you have a kid who comes in with repeat urinary tract infections, the first thing you're probably going to order is a renal ultrasound, okay, because that's non-invasive. Then after you've ordered a renal ultrasound, if you see evidence of hydronephrosis, okay, so that means water sitting on the kidneys, then you would consider getting a voiding cystourethrogram. But if they have normal kidneys after a urinary tract infection in their infancy, you wouldn't necessarily need to go straight to that VCUG unless they have another or recurrent infection. All right, so let's move on here. I'm gonna find my other good picture. I wanted to go over some things you see that are pretty common in practice. So one of those things is going to be, find the other one here. One of those things is going to be hematuria. The other one is proteinuria. I'm going to move this over here and put that there. All right, so if you have a child who comes in to see you and they have you've gotten a UA for some odd reason, and the kid seems fine, totally normal exam, but they've got microscopic hematuria, okay, so really small amount of blood in their urine. That isn't something you're going to be super worried about, all right? You're going to repeat, you're going to take a look at a repeat urine, you're going to talk to them about the family members. Do the family members have urine analysis that come back positive for blood also? If so, it is possible that there is something called benign familial hematuria syndrome, and it just is basically where it's genetic that you spill blood into your urine, but it's really not necessarily a severe renal or nephrologist consult or a problem, okay? So this really good algorithm will tell you, do they have isolated hematuria? You may want to check a calcium creatinine ratio. You may want to get a bacterial urine culture. And you will talk to them about their family members. But these things will depend on the history. If the kid does not have any complaints of a urinary tract infection, that's your provider discretion to say, okay, we're probably not going to go that route. We don't necessarily need to do culture right now. But if they've got isolated hematuria, they may have some kind of stone formation or hypercalciuria or something going on where you want to get a calcium creatinine ratio. Okay, and following this algorithm all the way down will kind of give you an idea of where do we need to go with assessing how far or how much of a problem this patient's hematuria is. Now, if you ever encounter a patient who has hematuria and proteinuria, that is a problem, always, okay? You must evaluate that patient for nephritis, especially glomerular nephritis, because whenever you have a patient who has blood and they're also spilling protein, the first thing you're going to be thinking about is a kidney problem at the glomerular filtration level, okay? Because it is very common to have a kid who has proteinuria. That you see it quite often actually in practice. It should not be present that the child has a proteinuria and hematuria. Now, you will see that at times with the urinary tract infection. So if you know that the child's got an infection, that's different. But if the child does not have what you would think is an infection actively going on in the urinary tract or pyelonephritis, and they've got blood and protein in their urine, you need to be thinking, I need to evaluate this child further for nephritis. Okay, and there are specific treatment guidelines for nephritis that you would refer to for that. But it's your main goal is to say, I know there's a problem if this child has hematuria and proteinuria together. Now, for the proteinuria, again, about 75% of kids who come in to see you with proteinuria will have a normal recheck urine. So when I say that proteinuria is really common, it is so common, in fact, that a yearly urine was taken off the guidelines for the Bright Futures for most kids over the age of 4 and 5 years old, because we kept ordering all these UAs and getting all of these abnormal urine results that came back completely normal once they did another recheck. So it wasn't becoming cost effective, and we weren't finding any problems in these children having all of these pretty random urine samples coming back abnormal with either just isolated leukocytes or isolated protein. And then when we rechecked the kids, or we did, a further testing, all of that was normal. So consider the fact that when you see a child who has proteinuria, they're more than likely going to have no problems that stem from this. In fact, in my years of practice with children in almost 20 years, I've only seen 2 children who have had proteinuria that actually ended up being a form of kidney disease. So, all right, so looking at this algorithm right here, we've got UA comes back positive for proteinuria. Is it possible that they have orthostatic proteinuria? Okay, so what that means is they are here to see you in the afternoon at 3 p.m. They've been standing all day, or they've been running around and very active. They're playing some sports, and they're spilling protein simply because they're standing all day and their muscles are spilling that protein into their urine. If that's what you think's going on, reassure the patient. Or you could even say, take this urine cup with you, go to bed tonight, pee for me your very first morning void, and then bring me in that urine and I'll test that instead, okay? So if you don't think it's orthostatic protein urine, then you may want to get a protein creatinine ratio, or you want to do a 12 to 24 hour urine collection, okay? This is where about 90% of the kids 95% of the kids, I would even say, you see proteinuria is going to stop. Because once you collect these 2 tests right here, or one or the other, a urine protein creatinine ratio is quite sensitive, and it's a great test. Once you order this and that comes back normal, you really don't need to do anything else, okay? Beyond this is where you would say, okay, and this is your results of these tests. Beyond this is where you would say there may be a problem. If the protein creatinine ratio or the 24-hour protein collection is not normal, then that's when you would need to do a more definitive workup to assess the patient's renal function, then also possibly consult with a nephrologist. All right, let's move this over, get out of here. All right, so the next thing I wanted to talk to you a little bit about was nephrotic syndrome. I want to pull up some photos here, because nephrotic syndrome is not fun, and it's quite sad to see in these kiddos. Up some things, give you a good idea of what you'll actually see on an exam. Okay, so nephrotic syndrome is a problem with excessive excretion of protein in the urine. And the problem actually starts with alterations in the integrity of the glomerular filtration barrier. So they've got a problem at the renal level, okay, at the glomerular level, and too much protein is being spilled. The main mechanism of the massive protein loss is because of glomerular permeability. So the problem is it's too permeable, okay? So protein is passing through these non-functioning and these improper glomerular or nephrons within inside the glomerular level, and it's causing too much protein to be spilled, which leads to third spacing and lots of swelling, and it really causes some problems with the kidneys, and these kids have to be hospitalized a lot of the time. They will get IV albumin to release that protein and to help them, not be so edematous everywhere. The classic definition of nephrotic syndrome is really just massive proteinuria, and that's one of the things that if you actually see these kids in primary care, you'll find on their UA, is just horrendous proteinuria. When you see a kid that looks like this or looks like this, they're not going to be spilling a 1+ protein. This is going to be a 3 to 4+ protein on UA, okay, greater than 40 milligrams per millimeter squared. And when you see a kid who has a history of nephrotic syndrome, sometimes they can grow out of this. It will start as young as usually toddlerhood. Haven't seen it much in severity younger than that, a little bit older infancy and toddlerhood. But when you would see them in primary care is probably not going to be when they look this bad. All right. By 9 times out of 10, by the time they have developed a condition like this, they have already been diagnosed previously at the emergency room. However, you may be following them, and then you have to follow them for exacerbations and then also follow up with any problems in collaboration with the nephrologist, because they're going to need well care just like every other kid. But it's important for you to know and recognize the signs and symptoms of exacerbation of nephrotic syndrome and also the pathophysiology behind it so you can talk to parents about what they need to expect. All right, so I want to see if I can pull up. Got some other good pictures here. Where's this picture? Scrotal. Oh, here we go. All right, so I've got this really nice table that is in your Burns book. It's about scrotal swellings, okay? You're going to see, if you work in infants, you're going to see common scrotal swellings, and it's important for you to be able to identify the differences in them, when they are a problem, when they need to be referred, when you can watch them, at what age they should be referred. So let's talk just a little bit about that, okay? The first one that you might see a lot is hydrocele. It is not uncommon for many infant boys to be born and have swelling on their testicular area, and that's what a hydrocele is. Okay, so they're born and they just have fluid around their testes. Okay, let me see. I think I have a good picture for that. Dr. Bias loves some good pictures. So, but when you see these little boys, it may even look like there's not even 2 testicles. It might look like it all just runs together and is one large testicle that seems kind of swollen with fluid. Parents will be quite concerned with it. Dads in general will be very concerned about their son's testicles, of course. That's really normal. But when you see them, it's really important for you to provide lots of reassurance, okay? So I have seen very few hydroceles that were actually a problem. Now, I know I had a better picture than that. I don't want to show, here we go. That one's a little bit better. That's pretty good. Okay. So here's a hydrocele in an infant, okay? And that's a unilateral hydrocele. Really, you see this left testicle that's swollen. It's got a lot of fluid on it, okay? But notice how the testicle, the scrotum, it's nice and pink. It doesn't look like it is dark in color or lacking blood supply. It's still looking kind of spongy. It doesn't look significantly swollen, okay? Because not every hydrocele that you see is going to look like that. Some of them are going to be a lot more swollen and maybe a little bit tight looking around the, here we go, here's one. This one's going to be a little bit more tight looking around both of the testicular area. See, this left or this right testicle is a little bit tighter. You can see it's a little bit more significant than this one over here. But again, these are really not necessarily something that you would need to worry about as far as surgical repair or any kind of concern until it gets to a past the age of 6 months. And this one is associated also with the inguinal hernia, so that's why this you see this picture here with this child who's having surgery. But here, this kiddo really doesn't need anything except monitoring and possibly referral if they still have a little bit of fluid on their testicles between the ages of 4 to 6 months. But most urologists will tell you that if they have fluid there, but they're urinating well, you don't see any kind of color changes, and they're not having any problems, then it's really fine for you to just manage them in primary care and then follow up with the urologist if you think there's any problems. Now, the next thing I wanted to talk to you a little bit about was a varicocele, which is like a bag of worms in the testicular region. And this you will really find in a little bit older child. It's something that you can see in grades of severity, but it's not something that would warrant any kind of surgical or repair until it gets over a high, over grade 1. It does require referral. You do want to have a GU specialist manage that. However, it's not an emergency. Now,